A patient presents to the emergency department with fever, headache, and nuchal rigidity. The clock begins ticking on a potentially fatal central nervous system infection. This diagram represents the emergency CNS algorithm. It is the immediate, mandatory flowchart every physician must initiate the moment these symptoms are identified. The very first step forces a clinical divergence. The physician must decide immediately if it is safe to perform a lumbar puncture to sample the cerebrospinal fluid, or if that procedure must be delayed. The decision rests entirely on the fails mnemonic, a set of absolute red flags indicating elevated intracranial pressure. These include focal neurological deficits, altered mental status, immunosuppressed states or signs of ICP, a lesion at the needle site, and seizures. If any single fails criterion is present, the protocol shifts. The physician must immediately draw blood cultures and administer empiric IV antibiotics. Only then is the patient sent for a cranial CT scan to evaluate the brain before a needle touches the spine. Bypassing this specific triage pivot has catastrophic physical consequences. Performing a lumbar puncture on a patient with elevated intracranial pressure creates a pressure gradient that can draw the brain tissue downward, causing fatal herniation. Looking at this matrix, we can see the macroscopic phenotypes that allow physicians to differentiate between two overlapping clinical entities. A patient with pure meningitis maintains normal cognition. A patient with encephalitis presents with profound altered mental status and seizures. Viral meningoencephalitis is typically driven by specific pathogen groups: enteroviruses, herpes viruses, and arboviruses like West Nile. While the vast majority of these viral etiologies can only be managed with supportive care, identifying the specific pathogen is critical because herpes simplex virus encephalitis requires immediate intervention with intravenous acyclovir. HSV encephalitis operates with distinct anatomical precision. It targets the temporal lobe, causing localized hemorrhage and necrosis, resulting in severe memory impairment and behavioral changes. Take the case of a young female patient who arrives with acute psychosis, memory impairment, dystonia, and autonomic instability. The presentation strongly suggests a primary psychiatric breakdown or a standard viral encephalitis. However, this is often anti-NMDA receptor encephalitis. Here, antibodies mistakenly attack the brain's NMDA receptors, an autoimmune response frequently triggered by an undetected ovarian teratoma. Correctly reading the macroscopic clinical phenotype is the only way a physician can trigger the highly specific microscopic and radiographic investigations required to find the true source of the disease. This table outlines cerebrospinal fluid analysis. Once a lumbar puncture is safely performed, this biochemistry serves as the objective arbiter of the central nervous system infection. The classic bacterial profile is an environment completely exhausted of resources by replicating organisms. It shows a highly elevated white blood cell count driven by neutrophils, severely depleted glucose levels falling below 40, and heavily elevated protein levels. The profile for tuberculosis meningitis relies on a lymphocytic pleocytosis, accompanied by high protein. Most critically, the glucose is virtually non-existent, often dropping below 10 milligrams per deciliter. In stark contrast, the standard viral profile shows a moderate lymphocytic pleocytosis, but the glucose remains completely normal, and protein is only mildly elevated. The table also reveals non-infectious pathologies, like the Guillain-Barré syndrome anomaly. The fluid exhibits albuminocytologic dissociation, a totally normal white blood cell count coupled with an immense spike in protein. Mapping the exact CSF biochemistry allows the physician to discard empiric guesswork and execute targeted, pathogen-specific therapeutic strikes. Before those specific fluid cultures return, physicians operate blindly. They must rely on strict algorithmic empiricism based entirely on patient demographics to select an initial antibiotic regimen. For the baseline population, patients aged 2 to 50, the protocol is a combination of vancomycin to cover resistant pneumococcus and a third-generation cephalosporin, like ceftriaxone, for meningococcus. For patients over 50, the immune system weakens against specific intracellular bacteria. Ampicillin must be added to the regimen to cover for Listeria monocytogenes. If the patient is immunocompromised or arriving with penetrating skull trauma, the algorithmic matrix mandates adding ampicillin and swapping standard ceftriaxone for cefepime, providing necessary Pseudomonas coverage. Neonates under 1 month of age are placed on a strict regimen of ampicillin and cefotaxime. The standard ceftriaxone used in adults is absolutely contraindicated in these infants. Ceftriaxone forcefully displaces bilirubin from albumin, allowing toxic levels of bilirubin to cross the immature blood-brain barrier and deposit in the basal ganglia, a fatal condition known as kernicterus. Deviating from this precise prescribing matrix based on a hunch leaves critical pathogens uncovered, representing a rapid and often fatal clinical failure. Beyond diffuse meningoencephalitis, certain pathogens behave as localized structural intruders. Tuberculosis meningitis operates on a subacute, creeping timeline, often presenting weeks after primary infection. TB creates a distinct radiographic signature. It produces thick, basilar meningeal enhancement that strangles the structures at the bottom of the brain, leading to focal cranial nerve palsies and severe ischemic strokes. A brain abscess requires an entirely different diagnostic approach. Because it is walled off by the body, patients frequently present with focal deficits and seizures, but with a total lack of fever. The radiographic hallmark of a brain abscess is unmistakable on a CT with contrast, a distinct ring-enhancing lesion completely encapsulating a core of central necrosis. This structural behavior extends down the spinal column. A spinal epidural abscess presents with a clinical triad: focal back pain, sudden neurologic deficits, and an elevated erythrocyte sedimentation rate. The pathogen is almost exclusively Staphylococcus aureus. The bacteria exploit specific demographic targets, establishing infections in diabetics, intravenous drug users, and patients who have undergone recent spinal procedures. When an epidural abscess is suspected, the physician faces a critical decision. Should they perform a lumbar puncture to culture the fluid, or do they order an MRI? An MRI of the spine is an absolute requirement. A lumbar puncture is strictly contraindicated because driving a needle through an infected epidural space will inoculate the clean cerebral spinal fluid, spreading the infection directly into the central canal. Understanding the physical architecture of the infection dictates whether a diagnostic test will identify the disease or permanently paralyze the patient. Failure to recognize the alarm symptoms of elevated intracranial pressure before performing a procedure results in a mechanical failure of the brain, herniation. Looking at this cross-section, the brain is trapped by the rigid, fibrous boundaries of the skull. As pressure builds, tissue must find an exit, resulting in 4 distinct herniation syndromes. In subfalcine herniation, the cingulate gyrus is forced laterally under the falx cerebri. This shift compresses the anterior cerebral artery, starving the motor cortex and causing profound contralateral leg weakness. In uncal herniation, the inner part of the temporal lobe is forced downward past the tentorium. This severs the oculomotor nerve, blowing the ipsilateral pupil wide open, while destroying the cerebral peduncles to cause contralateral hemiparesis. Central herniation drives the diencephalon straight down into the brainstem. The physical result is fixed mid-position pupils and rigid decorticate posturing. Tonsillar herniation is the terminal event. The cerebellar tonsils are forced entirely through the foramen magnum. The sheer mechanical force obliterates the brainstem, immediately arresting the patient's respiratory drive. Herniation is the physical manifestation of diagnostic failure. It is the direct consequence of breaking strict algorithmic rules designed to protect a closed, high-pressure system. The triage matrix demands absolute adherence to sequence. The immediate priority is always identifying the fails criteria and utilizing neuroimaging to secure the brainstem before a lumbar puncture is ever considered. Once the cerebrospinal fluid is obtained, survival depends on perfectly matching the patient's macroscopic clinical phenotype to the precise microscopic profile generated by the lab. Mastering central nervous system infections is an exercise in strict, unforgiving algorithmic empiricism.